Thank you very much, Honorable Chairperson and the members of the Portfolio Committee. Let me start by also expressing our best wishes to the members and compliments for the new year. We hope that 2021 will be a better year, and certainly I hope that the members have rested and they have a very challenging year ahead. And so one is hoping that we will continue to work together in the way that we have in the past. We have had apologies tendered on behalf of our team. The Deputy Minister is in a meeting which has been convened by the President, and so is not able to join us. The Director General is involved in the issues of our vaccine acquisition, the urgent matters that he's dealing with. And so we're not in a position to be here, but Anban Pillay, Deputy Director General, and other members of the team are with us in this discussion. Let me start also by conveying my sincerest and deepest condolences on the loss of the Honorable Janji. It was a very sad and shocking news to learn of her passing. We know her lifelong dedication to serving our people as a humble servant and as a doctor who has actually foreign countries to serve our people. We have worked together with her during the days of exile when she worked in Zimbabwe, Harare Hospital, Parirenyato Hospital, and some other hospitals in Zimbabwe. Having been trained as a doctor from Cuba, I was always struck by her professionalism and her respect for people and her dedication to her profession. So we were quite saddened to learn of her passing, and therefore wish to convey condolences to the family, to the friends, as well as to the colleagues and members of the Portfolio Committee, National Assembly, as well as comrades. I have also, there's a letter going to the Speaker's office, wherein, as Minister, I've also requested to make a statement to the House. And so hopefully one would have a sense as to what the scheduling would be like. But that, I believe it's important to also make a minister's statement on this matter in relation to the COVID-19 situation. I have noted the report about the letter from the EFF requesting Minister Mboweni. I can just say that I do know that Minister Mboweni would not have been able to attend. In any case, he's got a family bereavement, and he advised me that he was dealing with that situation when we had other issues to discuss. But issues that might relate to Minister Mboweni in relation to this matter that we'll discuss today, I will cover some of that. I'd like to just take you briefly to the history of our engagement on this matter. Firstly, to say that the nature of the pandemic has actually been quite devastating throughout the whole world. But a number of countries have faced what has been called the second wave, wherein the resurgence has come back to decimate more lives in different countries. We have been unfortunate as well amongst those countries that have had to face this second wave. And in this case, we have seen the country's figures going beyond 1,120,000. Excuse me. We've also seen the fatality rate going up beyond 30,000. We have also seen the numbers of hospitals getting filled up, particularly in the private sector. They've actually been much more under pressure. And of course, now it's spread to the public sector as well. The issues which have been of concern is that there's been a huge demand on beds, huge demand on oxygen, and demand for additional staff. So we have asked that there must be the reactivation of the beds that had been decommissioned in some of the areas, And our record so far is showing that in all the provinces that have been affected, mainly Eastern Cape, then Western Cape, then KwaZulu-Natal, now we're moving towards Gauteng. In these provinces, we have seen that the numbers have actually exceeded what was the total at the peak of the earlier surge. Now, Gauteng is still rising, and we still believe that it's going to be much higher than where we were in the last surge. KwaZulu-Natal has already gone almost twice the numbers of patients who are being admitted as compared to what it was before. You will also have seen that the same situation has happened in the Western Cape, where the numbers have far surpassed the peak that we had in the last surge. So the challenge, therefore, is that it's a little bit more severe than what we have had before. We have also had lots of pressure because our staff has been fighting the COVID-19 situation, and at a certain point, we would have liked to see them resting, but the surge returned even before many of them had been able to rest, and so the level of exhaustion is quite noticeable on our staff. So the major thrust this time around started with the Eastern Cape, and then it extended to the Western Cape, as well as the KwaZulu-Natal and Gauteng. So that has necessitated the need for us to embark on the stringent measures that have been put in place, particularly because of the nature of the festive season, where people will be congregating in large numbers, overcrowded situations, and therefore that was going to exacerbate the problem, taken together with the fact that there has been quite a degree of complacency in the use of masks. And so people were, I think, under impression that level 1 means that they will no longer have the problem. So this has been the challenge. But what has compounded this situation is the presence of what we call a variant. It's a variant which we call 501.V2, which is basically an indication of a slight change in the structure of the virus. Now, this is not only a South African phenomenon. We've seen a similar thing has happened in the UK. We've seen it in Brazil and Australia, although the variants are slightly different. And in our case, there has been an indication that our variant is quite different from the one that's happened in the UK. However, both the variants seem to be equally highly transmissible, and therefore the similarity between both the variants seem to be equally highly transmissible, and therefore so the challenge, therefore, that we have to deal with is that a lot of research is being done to look into the impact of this new variant, in particular the issue of to what extent is this more virulent, and there's no evidence that is more virulent. There's also no clear evidence as to what the impact would be of the vaccines, and so all of that work is underway, is being dealt with at the level of the researchers. So from that point of view, it's important just to say that there's a huge amount of experts in genomics that are doing work as a consortium across the country to deal with new information that comes from that level. I must say South Africa is working with a number of international partners as various countries that are advanced in this level. It is quite clear that we're dealing with cutting-edge technology here, so we will always know as much as anyone else in the world would know about this virus. Then it leaves us now with the one reality that is, excuse me, the reality that to deal with this issue, the only major source of protection is going to come from the vaccination program. And we believe that in South Africa, if it was possible, everyone should actually have the vaccine. But in terms of our current calculation, you need a minimum of 67 to 70% of the population to be immunized so that you can break the cycle of transmission. That is what we call the herd immunity, and that is based on a calculation that is made by scientists on the basis of the transmissibility of the virus in terms of how many people each person can be able to infect, as well as the various other factors that have got to be looked into to calculate what would be the safest number of people that would limit the spread of the infection. We then embarked on a program to collaborate with various partners in the world to look into the availability of the vaccines. And then we had agreed, at the time we started this discussion mid-year, the issue was in particular about two approaches. One approach was that we worked together on pooling the numbers of countries together to try and create a degree of safety by ensuring that we have large numbers of countries that can negotiate better prices. At the same time, we enrolled in the COVAX facility, which meant that they would be looking at about 9 vaccine candidates that would be working on to see which one would be successful. There were no results that were showing, except that everything had been done in the laboratories. So the other option was a bilateral agreement wherein countries were expected to put some contribution immediately and bind themselves to the fate of that particular vaccine, which meant that some of the amount that would be contributed would be non-refundable, but it meant we would be taking a risk on the particular vaccine, even though it would be a one-on-one. So we felt that the risk was too high between the two programs, and we felt that it was important for South Africa to work with those countries that would first find out what the most successful vaccines would be, and then we would then start following the issues from there. So we have then affiliated onto the COVAX facility, and then we committed for the payment of 10% of vaccine, which is worth 10% of the population. So there were a few delays in the payment of that vaccine. There were not, major issues that would have warranted the degree of anxiety that could have been generated when the payment process was a bit slow. So what actually happened in that case was that the Treasury had advised that what we needed to do is to raise the money so that there's no need to immediately tamper with the budget framework that had been tabled. And so we needed to look at what can be done, looking at the additional support that we got from the Solidarity Fund. And this was very helpful. And then it made the process to move fairly quickly. On the other hand, between Gavi, which is the Global Alliance on Vaccine Initiative, that Gavi was negotiating terms of the agreements. And in that process, those terms of agreement meant that there were to be guarantees. So there was quite a lot of discussion between the legal teams on both sides. That is what really caused the delay, to say what is the best way of expressing this kind of guarantee. And then between them and Treasury, it took a while to resolve that. But they had acknowledged that there was no risk to the South African participation in that process. And so that was ultimately resolved. And as we speak now, that amount of money was paid and guarantees were signed. And the amount that is guaranteed is actually in the budget, and that was sorted out between the Department of Health and the Treasury. So the issue of COVAX was actually sorted. So the president announced that, in fact, in terms of the COVAX platform, we were going to have we will have the first vaccine into the country around April, and that was the timelines that have been given to us by the COVAX facility. But by the time we got to that point, a number of results had now come out to indicate what progress we were getting in terms of the success of various vaccine candidates, and there had been a lot of announcements. On that basis, it gave us enough confidence now to be able to start engaging the various manufacturers. So there have been engagements on a bilateral basis with various manufacturers. There's been one platform. There's another platform, again, where the President Ramaphosa had created a task team which was looking at the continental access to vaccine, using the large volumes of the continent to actually leverage better prices. And so we started getting engaged in that kind of process. That process gave us a lot of insight in terms of what the various manufacturers were offering, what volumes, what quantities clear amongst all countries, particularly those with high-income countries, particularly in the West, US, the Eurozone, the UK, had actually committed funds on a risk hedge basis much, much earlier, a kind of luxury that South Africa was unable to afford because of our limited resources. And so they actually purchased literally each one of the several vaccine candidates long before even the results came out. Now, we were looking at that, and we were advised that, in fact, that was going to be much more riskier. But once the outcomes were beginning to come out in terms of the success of the various vaccines, we were then able to now start engaging. So we have non-disclosure agreements that were actually signed much earlier, from September, October, and so on. And these were basically to allow the manufacturers to share information with us, which would have been otherwise sensitive, which would have needed to be protected, as we're now trying to look at what the best ways of dealing with these vaccines would be. There will be a presentation that's going to take us through the kind of selection process of which vaccines we thought needed to be considered, as advised by our Ministerial Advisory Committee. You will also go into a bit of detail as to what is there amongst those particular vaccines. I think as we stand at this point, a few points that I think are important to mention is that, for one, we have had lots of discussion with the Minister of Finance, basically to say that the fiscus is going to carry the major burden of having to procure the vaccines. In the process, we've also agreed that we will look at and activate other means of raising additional funds, and that is the second way would be to approach the medical schemes and ask them to make a contribution, which will also be on the basis of social solidarity, wherein they could also cross-subsidize some of the members of the public. And the third one is to get donors, business to also make their own contributions. And so these together could be work together with the Solidarity Fund. So quite a lot of mechanics of making this system to move on are in place. The Ministerial Advisory Committee has given us an outline of a framework of what we needed to do, and that will be shared as well. Amongst the issues that were important were the question of prioritization of different sectors of society, starting with the ones who are most vulnerable, and then going right through in stages to be able to ultimately reach to all the members. So we have actually engaged a number of manufacturers, and we're at a stage where our discussions are fairly sensitive, and we believe that we should be able to conclude as much as possible. We did indicate that we were pushing to get now access to some vaccines so that as early as February, we should be able to get to that point. So I want to hold that for now, just to say that we'll take through the portfolio committee through the presentation, but also at the same time, it's important for us to note that there's quite a lot of anxiety in the society. It's largely because the resurgence of the COVID-19 has actually, kind of created a lot of panic with the numbers of people who are getting sick, the number of hospitals that are having, that are filling up, and the numbers of lives that we are losing, it is actually natural that we should all be anxious at this point. I'd like to just say that this situation will manage with the best of our abilities, but also we will be making sure that we bring the vaccines as quickly as possible into South Africa. By the time we start the vaccination program, we won't be very far different from many countries. We would actually be all in line with most of the countries. So we would like to assure the public that, in fact, we are all on course insofar as this matter is concerned. We have noted there's been quite a lot of comments and concerns and criticism coming from different parts on the public. We want just to acknowledge that, yes, the issue has to be debated because it's a matter of public importance, but that the government has actually been on course when the matter is actually being handled. There will be vaccines available. They will be available in stages in terms of the high risk of the population. That is, we will have advised, we will go through those priority lists as we move on with the presentation. That at the end of the day, South Africa has actually, as a country, been focused on the best possible way of dealing with this COVID-19 situation. And therefore, we don't feel that the anxiety must make people feel that we've basically got ourselves into a more difficult situation than any other parts of the world. Yes, some countries have just started vaccination. We will also be starting our vaccination program soon. And so we believe that the whole of next year we'll do our best to vaccinate as many people as possible. Our target being the 40 million people that we have put on as a requirement for the herd immunity. And of course, like any other countries, there may be challenges with the logistics. Will indicate how far we've gone with that plan. I want to leave it at that for now, and then say to Honorable Chairperson, if we could allow Dr. Anban Pillay to take us through the presentation. I will come back afterwards then to make concrete, to make the closing comments. And if there's anything that I need to also clarify on the presentation, I'll do so. Thank you very much for your patience. And if we could allow Dr. Anban Pillay to come on and table the presentation.
Okay. Yes, Minister, that has been extremely helpful. We will now move on to the presenter, Dr. Anban Pillay. But I think your opening remarks were quite detailed. They have been of great assistance on the matter that we are dealing with. We are beginning to formulate already our clarity-seeking questions to you, even based on what we have just said. But let us then move into the presentation as presented here. Honorable members, I've noted your raising hands, the wanting to speak, and I've noted you. Please go on our WhatsApp group and see where your name is appearing and indicate if the only person I have not indicated, I've put her there to speak, even though she didn't raise her hand, is Dr. Thembekwayo. You will also appear on the list. You can then decline when the time comes to you, but already look at your list that I've already formulated for members to ask questions. Thank you, Dr. Anban Pillay.
Well, can we ask the administrator to open up so that we can share? I can continue with that presentation. I'll make it quite brief because it sounds to me like Dr. Anban Pillay might have been having some problem. He was dealing with another sensitive matter as we were starting this discussion. So I will just table that presentation if we can be allowed to share. It said only the host can share, so I think we might all be having a challenge there. Could we be allowed to share?
Ms. Machalamba, can you assist us?
Is that visible, Chairperson?
Clearly visible, Minister. Thank you very much.
Thank you very much. Let me try and then walk through this because the understanding was that Dr. Anpan Pillay would be in, but I've just got a note that there's some crisis. So I think the numbers of issues that we're handling that right now. So I will just proceed. Basically, I think the first point which I want to make, if you look at the numbers as of the 6th, is 1.149 million. That was published yesterday. Then we have a case fatality of 2.7% at 31,000 individuals, with recoveries at 929. That comes to about just 83% or so. That has been an increase of late, which is indicating the severity of the second wave. The point which I think is important to watch here is that the first graph is showing on the left the first surge to June to August, which has now started again from end of October up to currently where we are. But the difference between the two is that the gray graph is showing how the Eastern Cape was the first, whereas in the previous one it was Western Cape that was the first. The Eastern Cape has already started plateauing, although we're still having a lot of reports then which were correcting in terms of ensuring the accuracy of the fatality numbers. But nevertheless, the number of new cases is already on its downward plateauing effect, if you can see. Then the yellow line or the orange is actually the Western Cape. And again, Western Cape, what is visible is that the Western Cape, the cumulative numbers, as you can see, the 7-day moving average, is already gone to twice the height of what it was in the first stage. In other words, when you get to the Western Cape health services, you will notice that they've run out of oxygen. They were to do emergency support for that. It's mainly because the numbers have increased far higher than what was previously experienced. KwaZulu-Natal, exactly the same. You see the numbers there. The current trajectory is showing that it's almost twice as high as what it was before. And next to it, rising steeply, is Gauteng, which is still going to show in the next few weeks when the people return to Gauteng after holidays. So we expect that the pressure is going to be building up onto Gauteng. Already as it is, it's already 2/3 of what the height was before. So the numbers are expected to be much higher. Then the other provinces have got similar kind of experiences. As you have heard, Limpopo, Mpumalanga, they've got issues that they are managing. So this is the indication of our second stage. This graph is showing already that deaths, if you look at the red graph, the deaths are already higher than what we ever experienced before. The admissions are already higher than what we experienced before. The new cases on a 7-day average are also already higher than what we experienced before. So we have then worked on the framework for vaccine implementation. Here we're looking at some of the governance structures and the system of what you need to do. So we have to look at the governance structures. We're looking at the issue of communication and stakeholder engagement. And then the whole flow chart that's talking about prioritization of the population, allocation of vaccines, distribution, supply to point of use, administration, and then issues of safety, and following up on second dose. Then a link to that, there are other issues which really depend on a huge data monitoring, supply monitoring and tracking reports and vaccine uptake, adverse effects, events following immunization. All of these are issues that you have to actually monitor with a very reliable data system. And then regulatory considerations and finance. Now, this point, I'll just highlight, I've made the point already. We need to prevent morbidity and mortality and ensure that there is a protection of the entire population. That's what we call population immunity. That becomes very important. And the principles of what we need to do with the vaccines is that the government must be the sole purchaser, and that we'll be using a multiple supplier approach, where we'll be using a number of players who are going to be supplying us. But just to know that if you get one dose from one company, you must get the same dose from another, from the same company. The second dose must come from the same company. You don't mix the two doses. And that we are guided by a Ministerial Advisory Committee, and that we have to have a pre-vaccination registration, and then must be a national register and a rollout committee. This is an outline of what would be in the committee, largely departmental, but then, of course, you've got SALGA, you've got private sector, you'll have civil society and WHO. Then other stakeholders that will continue to guide us here. On the one side, we're going to have to be having the Ministerial Advisory Committee, and that will all continue to focus on the issues of behavioral change, issues of technical issues around vaccines, emphasis on non-pharmaceutical interventions. Then the labor, we need to work very closely, because a large number of our health workers and some of the essential workers are going to be linked to the unions, and there are issues of safety that we've been discussing with the unions. We also need civil society here. It's important that we need to have societal buy-in onto the issue of the vaccines. Then, of course, some on the private sector, we're going to be working with the private health sector, medical schemes, hospital association, private hospitals, and pharmaceutical associations, and so on. Effectively, as I said, there are three ways of how we're going to be looking at the support from the private sector, pulling off funds to support vaccination, promoting the use of vaccine amongst employees, and provision of a vaccination platform on occupational health systems. Then identification of and prioritization of target population. Here we're guided by the Ministerial Advisory Committee. We're looking at those who are most at risk, and therefore we group them up into various groups. The first group are those who are going to be in high risk, who are highly targeted, so that we need to make sure that health workers, frontline health workers, are on the first category, which is our first phase. The second phase will also extend to those with comorbidities, the old is over 60, and so on. And we will then have quite a lot of activity on the second phase, and that will be linked to the availability of more quantities of vaccine. And then after that, this becomes a continuous vaccination that will happen long after so that on a continuous basis, everyone else gets covered. Then when we talk about health workers, basically all the categories of health workers, even though they are seemingly categorized here, but they will all be covered. And then, of course, phase two, we have to talk about essential workers. That covers those frontline workers, teachers, police, military, miners, and other people who are working in settings where they're serving communities. So the population exposure, the exposure to the infection because of their service to the community. So those are the groups of people. And then, of course, those with comorbidities are going to be the phase two. Those are the with underlying illnesses, HIV, TB, diabetes, and so on. Then there are a few issues which we're still resolving on the issue of vaccines. Pregnant women, we will not immediately include them until we've got the issue of safety properly indicated there. Then the other issue that we still want to get a bit more clarity on are the people who have been already previously infected. Do they get the antibodies? So that issue is being worked on, so we'll get proper advice. Then what do we look for on the vaccine? And this is how we've been guided. So just to decide whether the vaccine, because we had 200 candidate vaccines. So the ones that we are going to talk about are those where there's safety issues, efficacy issues, and immunogenicity has been well established. In this case, about 11 of them have got that kind of situation. So we can now start talking about all of that. Then secondly, we have to look at the supply. So, for example, if someone has got a very good, has got high efficiency, high efficacy vaccine, and it's safe and everything, but then it's too expensive, it might be an issue. But maybe it might be if the vaccine is good, but they are so booked, they're overbooked that they don't have vaccines available until 2022. Obviously, we can't deal with those. We have to look at others. So that's what is involved in all the negotiation. So we have to start looking at the ease of use, stability during the storage. All of those issues become important. Then the issue of cost and registration are part of what has to be looked at. So the number of vaccines that we're looking at. So, for example, we've looked at the Pfizer. In this case, they've already been registered, high efficacy, and then there are storage issues that we have to look at. Then the AstraZeneca is the other one that has also got some approval in some of the jurisdictions, very efficient, and both of these have got 2 dosages. And so the other one is Johnson & Johnson. Part of it is also being prepared in South Africa between Johnson & Johnson and Aspen. And so again, they are working on regulatory approval. And so we believe that we need to focus on this because it's very promising. Then we've got Moderna, which is already being used in the US, which we are looking at. Then there's also Sinopharm in China. And all of these are actually very high efficiency vaccines. And all of these now are what we've been looking at together with our Ministerial Advisory Committee. So we have to make sure that the issues of safety are attended to. On regulatory matters, they have to look at where they are registered and that they have submitted the necessary documentation. The process has to be done properly. But what we are having is that the SAPRA has got a special task team that is facilitating the registration of vaccines. They can also do authorizations in terms of Section 21, where manufacturers have not submitted dossiers. And if we think that all the evidence is pointing at the very useful vaccine, that can actually be also taken into account. So we have noted as well that there has to be, because of the new technology that's not been seen before, there has to be quite a degree of active and passive surveillance, which we're going to have to work together between the department, WHO, and SAPRA, just to make sure that everyone who's got a vaccine must have a kind of like a yellow card vaccine card system, which you keep, that always shows that you've actually had the vaccine, and the 2 doses will be recorded there and their dates of administration and so on. They also have to run what is called Med Safety app, which is to look at people with adverse effects following vaccine immunization. It's also important to make sure that we monitor because the development of the vaccine has taken place over a very short space of time. Then we're looking at various ways of distribution mechanism, and here we have to either look at central distributor, where we receive from the manufacturer to a central distribution, or you've got a situation where we've got a mixture with central distribution and contracted distributors, or you've got a situation where the manufacturers are contracted directly as distributors, or we have the supplier-distributor situation. That will then cover on the right public hospitals, vaccination centers, mobile clinics, private hospitals, pharmacists, and so on. So that is being worked on now so that we can we can refine the process as we move on. Then the issues of security, distribution security, vehicles must be tracked and all of that, simple basic issues of making sure that you don't have excuse me, you don't have a problem of tracking where the delivery, the stock is. And then, of course, the issues of tracking and tracing of vaccines with barcodes, so you know who got from which particular bottle, which particular batch it came from, and all of that. Safe disposal of a vaccine is going to be an issue. Verification of distributed volumes and what's been distributed, what's been administered. We need a whole lot of systems to deal with that, including the issues of monitoring wastage. So there will be a number of programs here, some in the phase 1 group will be having people who will be vaccinated from hospitals, where staff can be, just approached in the hospitals. And there's a whole lot of issues there because the slides have been distributed. I won't waste time. Then the other outreach programs, where we will actually have a team that goes out. We call that hub and spoke model. So you get one hospital, and then it rounds up all the clinics and the centers where health workers are, so that in that particular district, everyone is covered. So that's another way of looking at it. Then there are also vaccination centers. This works well in the urban centers. We've seen that happening in Europe, where they put up a center in a city because of the proximity within suburban areas. Makes it easy to access health workers that are needed, so they can actually move to that center and get vaccinated, and that should be it. So that is another way of. So those are the different formats of how this is going to be dealt with, and then. It's just the distribution within the health workers, so that where do you find EMS staff, where do you find health workers, community health workers, and so on. Then the other delivery platforms that have to be considered are pharmacies, mass vaccination centers, and then community halls, churches, and so on. So all of these, as you go on with phase 2 and 3, we're going to be considering a wider range of mechanisms. Now, these are indicative figures of what it would mean. For example, if you did 40 million people over 12 months, it's a huge task, and it means we'll have to really target huge numbers, 316 per day, and so on. When the machinery is working very well, it should be able to move up to that level, where each vaccinator can vaccinate 50 people per day. It's going to be quite a huge run. We're targeting about 6,300 people, and drawn from clinical associate, community service, doctors and nurses, contract nurses who are involved in other programs in vaccination, etc. So we're looking at targeting those people. For every province, we need each one to appoint someone who's going to deal with the cold chain management. And so that's the other issue. Then we have to deal with the integrity of the whole process to ensure that vaccine confidence increases because of transparency and the effective management of safety issues, and also ensuring that the reporting of any side effects that are detected, and I indicated the yellow card system, and I also indicated the safety issues. Those are going to be all have to be built into the system. The issue of training is going to be important. Our partners, civil society, business unions, all of them that have to be part of our communication system so that they can talk to the members out there and talk to the public. It's important to align the messaging. Right now, we've got everyone saying different things. It's important that we must actually send one message so that we are able to get everyone to understand what exactly the program is all about. So there's additional work that has to be done, development of materials and all the other issues that are indicated there. And so the need for a very strong electronic vaccination data system, which is national and centralized, so that you can always find. If you want to know if Zweli Mkhize was vaccinated, you must go and check somewhere. Maybe they lost their card and you want to now redo their card before they travel, so you can be able to do that. And so there's quite a bit of tracking of specific issues, the identity of the individual, who's the manufacturer, what's the batch number, what clinic administered this. All of that information needs to be dealt with. And so there has to be a link between NHLS and NICD. The issues of consents, for example, if someone says, I don't want the vaccine, if someone has to do the vaccine, they've got to sign somewhere as a kind of consent. So all of those issues are being taken into consideration. Then you must have a dashboard that's able to monitor. If you want to know every day how many people are vaccinated, you must be able to find all of that. So all of that information needs to be kind of recorded somewhere. Then there are responsibilities for the National Department of Health, which basically are around finalizing the model and establishing coordinating committees and also supporting the provinces. The same thing with the provinces. They've got to also do a similar arrangement where they've got to also go procure needles, swabs and everything, so that when all of this thing is put into operation, we can start the process. this kind of work here is a kind of work where you do the plan, that's one thing. But to actually make it work, it can only be proven once you've started to administer. Then you know what are the weaknesses in the system, and then you can strengthen it at that point. So we don't expect that everything is going to be perfect as we start. We believe that things are going to be strengthened as we go and we learn from the system. When we started the engagement much earlier, we're then trying to look at what could be the indicative figures. These figures are not really accurate, but they were figures that were based on just a kind of modeling process, just to say, what could it be? So, for example, if you were to take 5% of the one and 5% of the other and so on, I'm just giving you this as an example. This is not how it's going to ultimately pan out, but just to give you a sense as to, at the start, when the results came out, what were we looking at? So we then use that to guide what the quantum of resources that might be required here. So it doesn't say this is a budget. It says to us we have a sense as to where the cost is going to ultimately lie. So let me leave it at that with this issue, and then just make one or two other points. And the first point which I want to make is the fact that the Treasury has allocated amounts. It's not fixed at this moment, but they have come to the party to say they are working with health to make sure that health requirements for funding will be covered, and health is going to be dealing with all the logistics, the procurements, and so on. We're going to have a special kind of dispensation that's going to allow a deviation so that different manufacturers can be engaged, as we already currently are engaging them. There's quite a lot of discussion that is going on between the department and the various players to be able to get to a point where we can say we've got our orders confirmed, and so Treasury will be allowing the process so that there is no difficulty with the procurement processes, that you can speedily procure and purchase and pay and get receipt of the particular vaccines at a particular point. If I can just hold it at that, Chairperson, I'm sure there are many issues that I have left out, but the members might want to raise those, and then I'll try and deal with them as they come. Thank you very much. At this point, I'd like to hand over back to you, Chairperson. Thank you.
Okay, thank you very much, Minister Mkhize. Mkhize, you must have a big glass of water next to you. You made very detailed opening remarks, and we have now presented to us, and there are honorable members who would like to ask questions. Honorable members, may I request you, because these issues of critical importance, there are recordings that we are taking. We like to see and know who's talking. That is what the parliamentary staff has actually advised me. Number two, we are very welcoming to the media. This meeting has got 76 participants. And of course, we are just 11 of us in the portfolio committee. And there's 4 leaders from the Department of Health, including the Minister. There's going to be about 6 parliamentary staff supporting us. So there's been a huge interest on the media. And so this matter is at that level, Honorable Members. I'm just informing you. Please switch on your camera at the time that you are speaking. I'm going